I would like to thank the organizers for having me again. Thanks. I would like to congratulate Stacy and Vidhu for those wonderful sessions. Now we will move on to the next session of the day, which is Ejaculate versus Testicular Sperm in ICSI, an expert opinion. So, who is an expert here? I will quote some studies, I will try to share some personal experiences. So, some of the slides are going to be from my previous presentation, which we had an hour ago. So, I'm not going to dwell too much on those slides. So, again, the prevalence of male infertility is rising. It's close to 50% of all, and 10% is idiopathic. So, all those things we have discussed previously. So, what are the indications of ART treatment? There are many indications: tubal factor, ovulatory causes, IUI failures, endometriosis, severe male factor, and premature ovarian failure, and absence of uterus, male Rokitansky syndrome. So, in this, the spectrum offered to the patient is IUI, IVF, and ICSI. ICSI was invented by Palermo in 1992. It was a revolutionary science which addressed the concern for subfertile males, especially who had low motility and low concentration. So specifically looking at the indications of ICSI, it's oligo, which is a low concentration, acino, low motility, teredo, poor sperm morphology, defective head shape, head, tail or midpiece. Globosospermia, again it's a form of pteridozospermia. Repeated IVF failures also is an indication of ICSI because at times the sperm lacks the properties to penetrate the oocyte. So in those cases, like globosospermia also will never penetrate the oocyte. So in those cases also ICSI becomes an indication. They become an indication for ICSI. Anti-sperm antibody, low oocyte count. So all of this is a controversial topic, low oocyte count. Somebody will say we'll try to do an IVF, some people will prefer an ICSI. But if you are proficient in ICSI and the quality is good, ICSI works better in low oocyte count. In case of surgically retrieved sperm, which is actually the topic for the day, the testicular sperm, again ICSI is an indication because it's not a motile sperm, it's a very feeble sperm with a very feeble motility or twitching motility. It cannot go on to penetrate the oocyte on its own. Again, cryopreserved oocytes, once the oocytes are denuded, so you can't do an IVF on it. Just a video showing ICSI, you immobilize the tail. And finally, you position the oocyte as per the scientific evidence. Then you go in with the sperm, aspirate the ooplasm gently, and deposit the ooplasm and the sperm back. So this is the process of ICSI. But is it that simple? So can any and every sperm using the process of ICSI activate an oocyte to become an embryo? The studies have shown that low quality sperm may adversely affect ICSI outcome. So what do you mean by low quality sperm? Or how does one evaluate the quality of sperm? So if you look at the gross parameters, you will say the concentration, motility, volume, the right pH and the right total sperm count, total motile sperm count might be enough. But again, as I discussed in my previous slides, the RB may be good in number, but they may not be functionally competent. They may not have the right the artillery to perform their actions. So they are functionally incompetent. A lot of evidence has come where they say that the underlying genetic component which is associated with the impaired sperm characteristics may be the leading cause of worse ICSI outcomes with the use of abnormal sperm. So abnormal sperm can perform or it may not perform. If it performs, then the genetic component is intact. But if it doesn't perform, maybe there is some genetic something inside the sperm which is causing it to not perform it in a way. That thing is the concept of DNA fragmentation, which the previous lecture was also based on. Although the sperm with fragmented DNA may fertilize the egg with apparently similar efficiency as sperm without DNA, the negative effect of paternal chromatin is usually manifested by impaired development, especially after day 2 or day 3 of development, which is known as a late paternal effect, as well as early pregnancy loss. So the indications of DNA testing were recurrent pregnancy loss. So if you look at, I had shown this slide previously also, it says that infertile couples, high DFI is seen in 30% of men with abnormal parameters and around 20% men with normal semen parameters also. This was a beautiful representation of sperm in the natural passage versus sperm in a AART treatment. So if you look at this is the natural process and these are the barriers. After the semen is deposited in the vagina, these are the barriers: cervix, uterus, fallopian tubes, and oocyte has got its own barriers: pubulus, zona, ulema. So what this is doing, this is filtering out the dead, immotile, and defective sperm and enabling a DNA mature and a sperm with a DNA functional and competent DNA to penetrate the oocyte. So it's a complete process. But when you introduce IUI, you cut this process short. IVF, you further cut this process short. And in ICSI, you become the boss. You directly, take a sperm and put it in the oocyte. So no barriers. And this is the thing which we are going to discuss. You are going a step backwards. You are capturing the sperm directly from the testis and doing a testicular ICSI with a testicular sperm, known as a testi-ICSI nowadays. So you are finishing the barriers. Is it going to help or is it not going to help? Let's see. So the ART, the sperm selection and sperm processing in ART is a far cry from truly mimicking the natural selection, which we saw in the previous slide. So many barriers cut short with the help of ICSI. And the processing and the preparation leads to atogenic sperm damage. So I'm coming to the source of sperm now. Is the source of sperm important? So we have got two sources of sperm. One is the ejaculate, nicely fine moving motile sperm, and the other is a testicular sperm, which is lying, which doesn't move, or even if it moves, it just twitches once in 1 minute or something, and you have to catch it at that moment only. So the advantages of ejaculate are it's non-invasive, readily available by masturbation, and disadvantages are quality concerns, as I explained in the previous slides. Testicular sperm, again, advantages are it's very high in quality. The DNA is intact, and it has got a potential in azoospermic cases also. Disadvantage, the process is invasive, there is anesthesia involved, so anesthetic complications can result, tissue damage, intertesticular bleeding leading to fibrosis, and so that tissue, if it is fibrosed, the tissue is gone. And it has got higher aneuploidy rates compared to ejaculates. So what are the indications of testicular sperm? The established indications are a patient of azoospermia, and if the patient is not producing sperm, you have to take it from the testis. Ejaculatory dysfunction. Patient is unable to ejaculate, anejaculation. The sample has got a lot of dead sperm or necrozoospermia or very low motility. Or it's a case of previous IVF or previous ICSI failures. Then again, nowadays, the tendency is that in case of previous ICSI failure, with ejaculate you tend to go for the testicular sperm. Or a severe male infertility. In these cases also, we are cryptozoospermia. In other cases, we are, considering the option of testi-ICSI. So it has been shown that elevated levels of ROS can cause sperm DNA damage during sperm transport through the seminiferous tubules and epididymis, causing post-testicular harm. With this background, we start our presentation now and see whether it's actually helpful to do a testicular ICSI compared to ejaculated ICSI. So if you look at this Kernel study, the testicular sperm has a maximum number of undamaged DNA in azoospermic men, and if you take it from fertile men, the ejaculate versus testicular, the testicular is much higher. If you take the comparison between testicular and epididymal, because if there is a case of obstructive azoospermia, you will get sperm from the epididymis as well as you will get sperm from the testis. But your preference should be testicular sperm compared to a epididymal sperm. This was a meta-analysis by STVs in which he tried to compare the reproductive outcomes of testicular sperm versus ejaculated sperm in patients with high level of sperm DNA damage. So this is important. Patients with high level of sperm DNA damage. And he found that the DNA damage was much lesser in testicular sperm. And he also found that the fertilization rates were lower in testicular sperm, and they were higher obviously in the ejaculated sperm. But all other indices such as clinical pregnancy rate, miscarriage rate, as well as the live birth rate, they were much higher, and they all favored testicular ICSI. See, they all favored testicular ICSI. So he gave ample evidence to support the use of testicular ICSI in these cases in patients with high DNA damage. Although the DNA testing itself is supported by type C evidence, but yes, he did advocate the use of testicular ICSI. Another study by the same author, he measured that EFI in testicular ICSI was much lower compared to that in ejaculate. CPR or clinical pregnancy rate was higher, miscarriage was much lower, and live birth rate was again higher. So again, supporting the same evidence. So the fertilization rate in testicular sperm was 70.4%, which is similar to that in ejaculated group. And based on this data, we conclude the author concluded that testicular sperm should be the option of choice in patients with high sperm DNA damage in an ICSI program. Now, slowly people are trying to do a testicular ICSI in virtually all the cases in which they are encountering failures. This was a study in which it was found that there was a high rate of fragmented embryos, which is very normal, and fragmented embryos do improve with passage of time if you go to take them to day 5 or day 6, and they do implant also. But if there are failures due to fragmented embryos, the authors went for a testicular sperm, and they did recommend because they got success. So they did recommend testicular sperm as an option for couples with ART failure because of high rate of fragmented embryos. This, I think, was a step a little too far. They considered the testicular ICSI in case of fragmented embryos. They might have tried a few more cycles. So that's my own personal opinion. And in this case, with recurrent ICSI failures with ejaculated sperm and no previous live birth, again, the authors they got success with the use of testicular sperm, and they recommended that. And this is a common practice now. I've seen many centers who are advocating testicular ICSI in cases of recurrent failures with ejaculated sperm. So this is a meta-analysis by Abhyankar et al. And they did a meta-analysis, and they found that they reached a conclusion that it did not support the recommendation for men with cryptospermia to use testicular sperm in preference over ejaculated sperm. Now, cryptospermia is a condition where you might or might not get a sperm, and even if you get a sperm, it's very low in quantity. So what was the reason for this meta-analysis concluding this? Number one, they did analyze the SDF levels, because you hardly get a sperm. How can you analyze SDF levels? You need minimum 5,000 sperms to analyze SDF. Number two, the maternal age was advanced in most of the meta-analysis in most of the studies in this meta-analysis. Number three, which was very important, only one study had history of previous failures, which is very important if you are thinking of considering a testicular ICSI option. You just don't consider it because if you're getting a sperm versus doing an elective TISA, I will probably go for naturally ejaculated sperm, even if it's a case of cryptospermia. So another study from a different group, and they said that testicular sperm extraction is justified in patients with cryptospermia who fail to conceive by ICSI using ejaculated. So this still makes sense. So 1 or 2 cycles have failed with crypto. Now you can escalate to testicular ICSI. Just finishing in 3 minutes. Again, the author studied the effect of paternal age, and they found that in patients less than 35 years, the prognosis was much better. So if you are encountering a patient with cryptospermia, and in case a cycle fails, you can at least counsel the patient that it's good if you do it at a younger age compared to adopting the testicular ICSI option at a later age. Diabetic men, not much of a difference. It is generally proposed that diabetics have high rate of ROS damage, and the DNA levels are high, so you should go for a testicular ICSI, but no. Studies have not supported this. Now looking at the safety of testicular sperm versus ejaculated sperm. There are many studies which which support that the neonatal as well as the perinatal complication rate was comparable to that of ICSI with testicular ejaculated sperm. There was no difference in the neonatal outcome between the two groups, ejaculate versus testicular. Another a similar study in which they concluded that there were no significant differences between the neonatal health and other parameters. So this was again a study which said that there was a comparable neonatal outcome, but they also said that the live delivery rate per transfer of non-ejaculated sperm was significantly higher than that of ejaculated sperm. So the surgically retrieved sperm had higher live birth rate per transfer. So the European Association of Urology, they concluded that the recommendation for the use of TSA-XC in men with raised SDF, but then they said that it doesn't currently advocate the routine clinical use of testicular sperm in non-usospermic men with raised SDF outside of clinical trials. So it should be done on a trial basis, but not on a routine level. And the recommendation was strong. They also said that the patients should be counseled regarding the low levels of evidence for using a testicular sperm. And testicular sperm should only be used in the setting where there is evidence of raised ROS and raised SDF. Again, the European Academy of Clinical Andrology, they said that in cases of alveolar steroidozoospermia, the routine use of TSA-XC is not recommended. However, in cases there are 2 or more XC failures with such samples, then you can move on to testicular XC. So in the end, I would like to summarize by saying that SDF rates are lower in testicular compared to ejaculated sperm. But the existing literature doesn't support the recommendation of using a testicular sperm in groups of men with confirmed post-testicular damage in the need to ejaculate. And given the low to moderate quality of evidence, testicular XC should be reserved in men with substantial SDF undergoing ART, particularly those experiencing repeated failures with the ejaculated samples, whatever may be the reason, and in which the ART cycles have failed. Thank you so much.
It was a wonderful talk, sir. Like, actually, would you use an aspirated sperm or an extracted sperm? Because you are using it interchangeably in all your
So we are focusing on surgically retrieved sperm.
Okay.
So whatever gives you a sperm, the route, the modality doesn't matter. An aspirated sperm is as good as a biopsied sperm or a microsperm by microdosing.
But any particular indication where you go for an extraction compared to aspiration?
So if it's a case of obstructive azoospermia, then obviously your aspiration is going to work. Even in case of NOA, TISA does work. I have tried to many patients. TISA does work.
You presented many studies from outside our country actually, but AIMS is a great academic body.
So in AIMS there is no study. There is one study by the OSS group in which they have retrospectively analyzed the 10 years of the data, and they have come up with the statement that neonatal outcome is similar. So for that we had a couple of meta-analysis to show. So I didn't quote their study. Other than that, I didn't find any study by any Indian.
But have you started doing in your cases like a failure, XC failure earlier when you took testicular sperms, and how are the results there?
Results are better. But I have not found much difference between epidural versus testicular sperm. But yes, between an ejaculate and a surgically retrieved sperm, yes, definitely it is much better.
Previous failures, it's much better.
Much better. But then again, depends on the number of oocytes, and so it's a couple concept, So number of oocytes, quality of oocytes do matter.
So for a younger patient, it's better if you go early for.
That's what they said. In case it's a cryptospermic or a poor sperm parameters, it's always good to go at a younger age. That's actually a very generic statement which they have compiled into a study. Actually, the younger you go for a ART or natural conception, it's always better.
Thank you so much.
Thank you.